we'll give it a go from my phone instead. Okay. All right. Welcome, everyone, to the Board of Health. I know that we have a new Cass County representative, so welcome, Charlene, to the board. Happy to have you on board. Desi, other announcements that you have?
Yeah, just a couple things. As we go into next year, we've always had, for a long time, we've had these meetings on Fridays. And really the reason that they ended up on Fridays was we used to have a dentist on the board, and that was the only day that they were free, was on a Friday. So before we make next year's schedule, I am going to have Lori just kind of send out a little survey to all of you to see if Friday actually is your day of choice, or if there might be another day that works better. We would probably stick with the noon time, because I think for many working, noon is much better. So just kind of watch for that going forward. And like I said, if we land on Fridays and that's everybody's choice, that's great. We just want to give everybody the option to say what works the best for them. Also, flu shot season, along with COVID season. So just remember to get your flu vaccines and be prepared for that. Our health systems are pretty busy, so we want to keep everybody as healthy as we can. And then also October is Breast Cancer Awareness Month. So that's that annual campaign to raise awareness about the impact of breast cancer and promote routine screening. So we do have the Women's Way program at Fargo-Cass Public Health, just as a reminder, that pays for breast and cervical screenings for eligible North Dakota women. So, and just show your support throughout October by wearing pink. So that's all I have for announcements.
Well, you were ready for it. I should have been wearing pink today. Thanks, Desi. All right. So I think the next item on the agenda is just an update on Board of Health responsibilities. And I thought this was pertinent to share with the group today, because I think given the environment that we live in, I just want to remind the board, and I know I've done this multiple times, that it's our responsibility to advocate for the health of the public. And there's been a lot of political tension that has resulted from COVID and, not just across the country. And so I think it's important, and I'd like to update our Board of Health responsibilities to really emphasize the following. So here's what I'm proposing to add to our responsibilities. So Fargo-Cass Public Health remains a politically neutral agency focused on evidence-based practices that reflect the mission and vision. And of course, the mission and vision is to prevent disease and injury, promote wellness, and protect community health. And while we recognize the members of this board have political beliefs, the objective of each Board of Health member is to uphold the mission and vision of Fargo-Cass Public Health, and all the efforts are made to remain unbiased in our analysis and guidance that we provide. So that's what I'm proposing that we add to our list of responsibilities. Again, given everything that's been happening nationally, I think this is kind of critically important that we lay this part out in that document. Anybody have any questions on that at all?
Chelsea, this is Arlette. Are you looking for a motion to amend, or is that what you're looking for? Okay. Well, I will so move.
Thank you, Arlette. Is there a second?
This is Lynn Telford. I will second.
Okay. Thank you, Lynn. Any discussion? Okay. Maybe a roll call vote, Lori?
Amy Lavella,
Approve.
Kayla Nelson,
Approve.
Lynn Telford,
Approve.
Charlene Nelson,
Approve.
Arlette Preston,
Aye.
Robin Nelson,
Yes.
Dwayne Breitling.
Yes.
Not here yet. Bernie Dardis. Oh, okay.
Yes.
and Chelsea Matter.
Yes. All right, thank you. So next up on the agenda is the approval of the minutes from August 13th. Anybody have any edits or from those minutes? Otherwise, I'll entertain a motion on approval of those.
Motion to approve.
Brightling so moves.
I don't know who was first and who was second. Was that Lynn?
I will second.
Okay. All right. All those in favor signify by aye.
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 Any
Aye.
opposed? Okay. Minutes are approved. Next thing on the agenda is Ladora to give a nurse family partnership overview. Nice to see you, Ladora.
Thank you, Chelsea. And thank you for this opportunity to share more about the Nurse Family Partnership Program here at Fargo-Cass Public Health. Just want to start out with a little history on NFP. Back in the late 1990s, a group of community members came together to research different evidence-based home visiting programs to bring into our community, and they chose the Nurse Family Partnership Program out of Denver. It is evidence-based nurse visiting program serving first-time pregnant moms and starting in their pregnancy and all the way until the child turns 2 years of age. And so then in the year 2000, we enrolled our very first client in May. So before I start the rest of the presentation, I want you to actually hear from some of the clients, the nurses throughout our nation, and some of the staff that are working at the National Service Office in Denver. So Brian, can you play the video for me, please?
When I found out I was pregnant, it was the summer before 12th grade. I was so scared.
It was really difficult not having my mom, my dad. As an immigrant, I didn't know how things were working here.
I was at rock bottom, and I found out I was pregnant. I want better for myself and better for my life and his life.
Prenatal and infant and toddler development may be the most opportune time to make lifelong effects on human development and health.
Nurse Family Partnerships intervention offers a multi-generational effect. Strong moms raise strong children become strong parents.
With Nurse Family Partnership, we support families in meeting their health and wellness goals for their physical health, but also what it means to be a healthy family.
When a mom has confidence in herself and her abilities, she's going to translate that down to her child. It's going to allow her to work with her child throughout many years as they deal with other challenges that they're going to come up against. When you talk with our moms, most often they have challenges such as homelessness, addiction, they're socially isolated, and that's where Nurse Family Partnership comes in.
No solamente la palabra, sino en dos idiomas.
I feel like I'm the support for them, but they're learning themselves, and it's amazing how they learn that they have the power, that they're powerful.
I was in a very bad spot when I found out I was pregnant. I was getting high. I was very nervous and scared. And then I finally sat down and thought, and I went to John Brooks Recovery Center, and I got put on methadone.
It's very common when somebody's going through addiction to have some type of trauma, something that happened in their life that they are trying to cover their pain with their addiction. So I helped her with resources to start counseling.
Dawn helps me with everything, learning how to take care of his needs and take care of mine at the same time.
James is a very happy, alert baby. His development is right on track. Now he's already attempting to try to crawl. He's a gorgeous baby.
Dad. Katie has helped me with a lot, and I think she might be my biggest supporter, honestly.
With Vicky, I feel she replaced not having a family. She feels like family. She is family now.
She's always there. It's not just for the nurse part. She's there for everything.
I can't imagine having done all of this without having been in the program.
We see long-term effects of the intervention on outcomes that are of unquestionable public health and social importance.
Since 1996, we've reached over 269,000 families. If you can change a family, you know you can change a community.
We're at this point right now where we have the opportunity to really scale up based on 40 years of success. We're going to reach the scale that's going to make a real impact in this country.
I want to just be the best mother I can be. I know there's going to be challenges, but I'm okay and ready for that.
Thanks, Brian. I've seen that video several times, and it always brings a big smile to my face. So as they mentioned, that NFP is an evidence-based community program, and it has been 40 years plus of evidence showing that significant improvements in the health and lives of those first-time moms and children living in poverty. Next. So Dr. David Olds, in his earlier part of his career, was working in a child care center, and he was seeing problems with some of the 4- and 5-year-olds, and he was thinking to himself, how can we make their lives better and the lives better for their families? So he started his research with having a nurse go into the homes, working with the families, starting pregnancy. So this is his comment, that there is a magic window during pregnancy. It's a time when the desire to be a good mother and raise a healthy, happy child creates motivation to overcome incredible obstacles, including poverty, instability, or abuse, with the help of a well-trained nurse. Next. And NFP's vision is a future where all children are healthy, families thrive, communities prosper, and the cycle of poverty is broken. Next. So here's a map of where NFP sites are located in states. So right now there are 41 states that have at least one NFP site. 41 states, excuse me. Also the U.S. Virgin Islands and some of the tribal communities. So since the replication in 1996, we have served over 300,000 families. And when you look at the return on investment, for every dollar invested at NFP, saves $5.70 in future costs for the highest risk families served. So we look at North Dakota, we've been serving Cass County residents for 21 years. And I'm happy to report 2 years ago that Bismarck-Mandan implemented an NFP program there. And they cover 5 counties right around the Bismarck-Mandan area. So in North Dakota, we have 2 sites. Our neighboring states, Minnesota, they have 7 sites serving 39 counties and 2 tribal nations. South Dakota has 2 sites serving 19 counties, 1 tribal community, and then Montana has the 1 site serving 4 counties. What is so nice about NFP is when our families move from state to state or county to county, we can transfer their services to another NFP site. So in Cass County, if a family moves into our county and they've already been seen by an NFP site, we can continue serving them. Same as when our families leave our county. So I'm very happy that now we have another county in North Dakota. Next slide. So we know how to positively transform the lives of vulnerable babies and mothers. We go family by family, day in and day out. By changing families, we change communities, zip codes, states, we can change the country. So if one family can break the cycle, so can many others. Next. NFP has 3 main goals. It's to improve pregnancy outcomes, improve child health and development, and also to improve the economic self-sufficiency of the family. And by doing that, that is with nurses going to the homes, working on during pregnancy, decreasing or quitting smoking, making sure that they're seeing their OB doctors, healthy eating, signs and symptoms of danger signs. For improving health for the child, they talk about, parenting skills. The nurses go in, they weigh and measure the infants. They educate on safe sleep environments, just to name a few. And then improving economic self-sufficiency. Nurses work with clients. They're always working on goals. It may be to finish their GED, to get their high school diploma. It may be they're interested in empowerment classes and transitioning into the Jeremiah program. So those are some of the things that the nurses work with the families. Next. And how do we meet those goals? We use specially trained nurses. All of our nurses are registered nurses, bachelor prepared, and they have 3 different trainings initially before they start seeing the families. They use motivational interviewing to elicit behavior change with the families, and it's that nurse and mom relationship that really makes a difference in the changes in that mom's life. It's proven with that extensive and compelling evidence of over 40 years. Also a very intense program. We enroll all of our moms before their 28th week of pregnancy. We prefer earlier in pregnancy, like 12 to 16 weeks, but we can enroll them right up to the 28th week of pregnancy. And we follow them all the way until their child's 2nd birthday. Most home visits last about an hour, and we see them weekly the first 4 to 6 weeks upon enrollment, then every 2 weeks until the baby's born. And then once baby's born, we go out there every week for the first 4 to 6 weeks, and then continue every 2 weeks until the child's 21 months. And then we transition to monthly home visits during those last 3 months. But if a mom gets real busy with maybe she's working full time, going to school, and just feels real overwhelmed, we certainly work with the families and have a flexible schedule with maybe seeing them every 3 weeks. And once again, very timely. We're looking at those first 1,000 days of the baby before the baby's born, and then until the baby turns 2 years. Okay, next. And the importance of that first 1,000 days for the baby. Early experiences influence the developing brain. Toxic effects of chronic stress, so we can help reduce the stress on the mom during pregnancy and also in the home environment once baby's born. Adversity can lead to lifelong problems. Early intervention can prevent consequences. So nurses are screening the infants for development, and if there are any delays or they're not meeting milestones, the nurse can talk with the family and then refer them to early intervention. And we know that a stable, caring relationship is essential for that baby's development. Next. This is a graph. The gray area is actually when a mom is in the NFP program. So you'll see to the far left, that would be early pregnancy. The yellow line marks were when baby's born, and then the pink numbers are the months of age until the very far right, that last year when we're in the homes. So if you look at development, the blue line is the sensory pathways for that baby. That's more of looking at the vision and hearing development. The green is language, and then that dark pink line would be the higher cognitive functions. So we are in there during that very crucial time for that infant's development. Next slide, please. So NFP is a gold standard of research. Dr. David Olds and his team had 3 randomized control trials, and the trials were designated or designed to study the effects of the NFP model. They wanted to study the short and long-term outcomes of the mother and children, enrolled in the NFP program versus those in the control group that did not participate. So he started out in 1977 in Elmira. In 1990 was the study in Memphis, and then in 94 was in Denver. Both Elmira and Memphis used registered nurses going into the homes. And then the third, they looked at, do we need nurses? Can we use another profession? So they decided to look at nurses going into the homes and using paraprofessionals, and they found the outcomes were remarkable to continue with having the registered nurse going to the home for the positive outcomes. Next. So these are some of the trial outcomes that they found in at least one, if not more, of the trials. A 48% reduction in child abuse and neglect was found. 56% reduction in ER visits for accidents and poisonings. 50% reduction in language delays of child aged 21 months. 67% less behavioral and intellectual problems at age 6. 79% reduction in preterm delivery for women who smoke, 32% fewer subsequent pregnancies, and 82% increase in months employed. Next slide. This is a list of the funding sources throughout the United States sites. Here in Cass County, we are funded through general funds. We also receive Medicaid reimbursement for the moms and infants on MA. And then United Way has provided funding for us for the past 9 years and will continue for a couple more years with that. Next slide. So in North Dakota, or with all the sites, the nurses start collecting data on the mom, the first enrollment home visit, and then she continues collecting data on mom and infant all the way until the child turns 2. So this is some of our data from our site here. 91.7% of our babies are born at a healthy weight. 90.9% babies are born full term. 83% of our mothers initiate breastfeeding. 33% continue to breastfeed when the child is 6 months of age, and almost 20% continue when that child is 12 months of age. Our babies, there's 92.4 of them have received all of their immunizations and up to date by their 2nd birthday. And I just put in a comparison for the Cass County general population at this 24 months would be 73.3. Next slide. So more data, they looked at our information, and 24% the relative change in cigarette smoking among NFP moms during pregnancy. We looked at the data when we first enrolled mom and then at 36 weeks gestation, like a month before she delivered, and saw there was a decrease in smoking. 74% of our clients who are 18 years and older were employed when we discharged them from our program when the child is 2. And there was found a 47% reduction in experience of reported violence. And we gathered that information at intake, which would be early pregnancy, compared it to when the child was 1 year of age. Next slide. So I gathered information from when we enrolled our first client back in May of 2000 until August of this year. And so far we have served 1,637 families, a total of 1,206 infants and toddlers, and we're looking at 40,514 home visits that have been completed. Next. So our NFP team serving Cass County residents, we have 1 administrator, and that is Desi, myself, the supervisor. We have 7 nurse home visitors and 1 office associate. Next. Okay, are there any questions you have? I mean, it kind of went through this quickly, but are there any questions that you have regarding our NFP or what a home visit might look like?
Yeah, thanks, Ladora. A great program. Folks have questions? Robin?
So is this through a referral basis? And I apologize if I missed it. How do you find clients?
Okay, so our main referral is WIC, and then the 3 health systems would be our second referral. But we can receive the Perry Center, the school nurses, counselors. Clients will sometimes know another family member or a friend. Anybody, even if a neighbor's was pregnant, they could refer themselves even. So, but WIC and the 3 clinics are our main referral sources.
So Ladora, a follow-up to that, are your staffing levels adequate so you are able to not turn anybody away?
Yes, right now we actually have room to enroll more clients, but I've been supervisor for I think close to 14 years. And in that time we did have waiting list twice, but we were still able to enroll the clients. We put a couple into MCH program, but we were able to enroll everyone, maybe not as early in the pregnancy as possible, but before the 28th week.
Thank you.
Chelsea, this is Arlette. I have a question. So do you have, is there a qualification in regards to income for the program?
Yes, if they're on WIC or MA, they automatically qualify, and we go by the 200% poverty level.
Okay, so you can't get in it if you're above a certain income level.
Correct.
Okay.
Like if we have a 22-year-old mom, married and making X amount, we don't enroll them. Part of that is because they looked at the largest impact was with the lower income. They had less resources and support. Good question, Arlette.
And 200%. I mean, that would cover anybody on expanded Medicaid as well.
Mm-hmm. Yes.
Okay. Yeah. Other questions?
This is Dr. Lavala. So if there's somebody who is more than 28 weeks pregnant, would you still serve them? Would you still be able to get them into the program, or are there comparable services that could be offered?
Yes. If they're beyond 28 weeks, we would not enroll them in our NFP program. Because it's an evidence-based program, we have 19 model elements, and that is one of the model elements. So we also have a maternal child health program that has specific eligibility criteria. So we would definitely look and see if they would qualify for that program, which would be registered nurses, again, going out into the homes.
Great, thank you.
Chelsea, this is Arlette again. So it sounds like there are some people that might fall through the cracks. Is that right?
You mean like because of their income?
Well, no, because of the gestational age and if they qualify for the other program or not.
Yeah, if they're like beyond 28 weeks, then we try and enroll them in our maternal child health.
But there's qualifications for that program.
Correct.
That they may not meet?
Yes.
What are the qualifications there?
For MCH, it would be any kind of, if they have domestic abuse within the relationship, homeless, if they have any kind of mental health diagnosis. Typically, I rarely turn anyone away because whoever's calling me, they typically would feel it, be eligible for either program.
Okay. Are there any income requirements on that one?
And maternal child health, no.
No, okay.
But those who do come into that program usually are on either WIC or medical assistance.
Okay. So it sounds like if there's a need, there's a ability to take them. Is there capacity issues at all with that program?
Maternal child health, no.
Okay. Okay.
Occasionally I'll get a phone call, someone just looking for a car seat or something like that. So there's resources in our community that I can send them to Safe Kids, Fargo Moorhead. Okay. Some resources from in the community.
Okay. I'm curious, just from an awareness standpoint. So if you're getting referrals from WIC and the healthcare, the three clinics, which I assume Family Healthcare is maybe a part of that, Ascension, just wondering if there's receiving referrals from other practices that might run into it. Just trying to think through other, touch points that folks might have.
I was thinking of the college student health centers.
Yeah.
Yes, we've reached out to them also, like the women's clinic. We are right now working with the National Service Office on getting the QR code on our brochures to go right to our website instead to Denver. So then we've done, out in the community outreach before, but once that is materials are ready, we're ready to go back out into the community again.
Okay.
Because even if we've reached out to Minnesota colleges, because our North Dakota residents, of course, they're going to some Minnesota colleges. So we have been to both M-State and MSUM.
Okay. Any other questions for Ladora? Okay. Well, appreciate your time, Ladora. It's always good to get a refresher in the program and to expose folks that maybe haven't heard of it. It's a great program, and let us know if there's things that we can do to help boost participation from our vantage point. So, okay.
Okay, well, thank you.
Thank you. All right. I believe next on the agenda was the Fargo Youth Initiative, but it sounds like we had some scheduling issues, so we'll hopefully get them next time. And then I don't believe Melissa's on, but are you going to cover the budget piece?
Yeah, it's in your packet, so you can just take a look at it. If there's really specific questions, we can get them to Melissa. Her overview to me was everything, numbers are looking good. So we're kind of where we should be. Some of the grants and stuff that show that much hasn't come in, they may have just started, in the late fall. Some switch over that mid-year instead of on a January calendar year. So that was really her only comments at this point.
Okay. Anybody have any questions? Okay. All right, Grant, you're up next. Massage ordinance.
Good afternoon. Thanks, Chelsea. I'll wait for my slides to come up. I can't see them. There we go. Okay, today I'm going to give you an overview of the proposed City of Fargo Massage Establishment Program. Next. Here's our agenda real quickly. Different things I'll go through, try to make it a timely thing and save a little bit for the end if you have any questions. So first we'll roll in the program background. Next. Okay, the program background. The steering meeting composition consists of myself, Captain Chris Helmick of the PD, Alyssa from the City of Fargo Attorney's Office, and then Michael Redlin, our Assistant City Administrator. So we were the initial ones that met, and this fell into environmental health's lap because we have a current program and ordinance that regulates body art and piercings. So there was a possible need for this massage ordinance program, and so they thought it was similar, not completely apples to apples, but they thought it replicated body art the most. So they asked me to put something together and deliver a product to the City of Fargo Commission. That being said, I've kind of done the coordination and folks in my department have helped me develop this program that we're going to push forward to the commission to see if it gets approved and implemented. It's taken a while just because we want to make sure the last thing there is about industry input meetings. And we've actually conducted 3 of those because I'm no expert in massage, and we want to make sure, just as in any program, we get feedback from the people that this would be impacting, or shouldn't say impacting, assisting with their program, and hopefully, tailor it, and we've molded it to what they would like to see based on those industry input meetings. Next. Thank you. So the purpose and intent of this program, the first, I guess, void, I guess you'd call it, is that we started looking around doing our research is administrative code does have a code, the state code for massage therapy establishments. But the big but is here, the governing body, the board, North Dakota Board of Massage Therapy, does not license individual massage therapy establishments. Okay, so what the board does, the next bullet down, they have very stringent individual massage licensing therapist requirements, which really complement the program that we're proposing, because they make it so it's very stringent to be a massage therapist, and we're basically going to verify they're doing what they say they're doing according to administrative code in these establishments. So what we found out is doing research that implementing a program for massage therapy establishments is a means to ensure the health, safety, and welfare in the community. We've also understanding that by implementing this, it will also uncover and possibly address illegal activity it has in other communities associated with massage therapy or illegal operations using this business or business model as a cover-up for illegal activity. Next. So the key differences between what we're proposing and the state requirements, the City of Fargo program will license specifically massage therapy establishments, not individual massage therapists. That's done by the state. Therefore, it would not be a duplication of government services. One of the powers and duties of the Board of Massage Therapists is conduct randomized periodic inspections of massage establishments. But their website specifically states the board does not license massage establishments. If you're interested in starting a massage establishment or practice, check with your local jurisdiction for new business ordinances and guidelines. So where do we fit in? Well, the City of Fargo does not have, at this time, we don't have any current ordinances or guidelines. So we're trying to propose these to fit that void. We're trying to get requirements and ordinances. So if somebody starts one, or if we implement this for the ones that are already current, it will cover them and the establishments there, again, not the therapist. Furthermore, right now the board does periodic randomized ones. Ours will be more proactive, and we were proposing to do annual inspections each year, obviously, using the administrative code, the requirements that are already specified in the administrative code for health and sanitation. We're just going to be enforcing those, but it'll be more proactive annually. Also, a key point is the board, North Dakota Board of Massage Therapy, only has the ability to take action against licensed individuals, not establishments, and has very limited jurisdiction or authority over unlicensed individuals. Next. Thank you. So this is just a snippet we took directly from the website, the board's website. And you can see, obviously in bold there, it says they do not license massage establishments, and I already told verbatim there in the previous side, but this is where they direct people to us. So once again, we're trying to establish ordinances and guidelines or requirements that fit this void. Next. Thank you. So sorry about the small print here, but obviously, like I said, we've been busy with this, and you can see the time frame. I'm not going to go through each one, but this dates back to February, where we had the City of Fargo Commission direct the attorneys to work with us. And since then, we've conducted, like I said, 3 massage industry input meetings. We've had several internal meetings with administration, with PD, with the lawyers, with a lot of people to finalize our details of the program. So where does that lead us down to? Right now, you go down between October 6th and October 22nd. The last meeting we had, we sent all inputs and all the revisions, and we really molded it. Had really fulfilling, I guess, conversation and thorough conversation with all the industry that was there or either online. So what we did was took all their input, their comments, whether emails, whether at the meeting, we put in a final draft copy. That draft copy is out there for their reference and a solicitation period that they can give us comments and further suggestions until October 22nd, which is next Friday. The following week, we will put it all together and do a final copy, which will turn in administration for the November 1st commission meeting. At the November 1st commission meeting, this is solely going to be for receive and file at their level with no public input. On November 15th, this is where I will literally be giving this presentation to the City of Fargo Commission, and then that will be followed with public input if anybody chooses to do so. Then the second reading will be November 29th, will be the second reading and City of Fargo Commission vote with public input. And if it passes, the tentative start date to implement this would be January 1st, and that will include licensing fees and the annual inspections. And then we'll enforce those requirements as well as get people that are licensed that aren't currently licensed. Next, please. So this was spirited conversation at the last industry input meeting because they really wanted to know how's this going to work as far as licensing specifically. So as you can see, the following business models or establishments will be implemented for licensing. So essentially all brick and mortar establishments. You know, if I have Grant's massage establishment, we're going to license me. Now, I don't need to be licensed through the state board. If I am, I have to pay, obviously, my license fee through them, and then you'll have to pay for this establishment. But if I'm not licensed, I don't need to be as far as an individual license. I could just own the establishment and then hire licensed massage therapists, that are approved through the North Dakota board. Massage therapists who rent commercial space would also be individually licensed. But we have a lot of those practices with it, whether it's in a hair salon or some kind of salon or a commercial building. We're going to individually license those therapists. You know, if it's Grant and Joe's massage establishment, we can split that fee, but that'll be our license. Now, if there's two people in a salon, but we're individually licensed, and that's my business, then, you know, Joe will get his own license and I'll get my own license. The license will not apply to in-home businesses or massages conducted directly in a patron's home, since residential businesses are governed by the Land Development Code. And the last one is all exemptions defined by the State Administrative Code will apply. So those that are, you know, massage instruction schools like NDSU, if the trainer for the Bison, I mean, we're not going to license those individuals, which is already spelled out specifically in Administrative Code under exemptions. The proposed fee, which we collectively agreed on internally to propose, is $100 per licensed massage therapy establishment license. So $100. To put it in context, we actually charge $250 for a body art establishment that's brick and mortar. But this was a hot topic because they don't want to be double licensed. They think it's double jeopardy. But like I pointed out, it's not a duplication of government services, because the state is directing us or establishments that are going to open to go to their local ordinance or requirements. So we're proposing a $100 fee that might be open for debate at the commission meetings. Next, please. Here are the program contact. There is our committee or our contacts for the program, which I already kind of defined earlier. And next slide, please, will end us on questions. So hopefully I didn't go too quickly in that, but I wanted to make sure, once again, I got through that information and save time for questions, which I'll entertain at this time.
Questions for Grant? I think you did really
Dr. Zavala.
Oh, go ahead.
Oh, I was just going to say, so on your slides, it said that you had emailed the draft of proposals to the massage establishments. Was that emailed to everybody, like all of the different establishments in town, or just the ones that were involved in the initial input meetings?
Yeah, great question. And we'll go back and let's go to the first industry meeting. And we reached out to the board and I said, can I get a list of the massage therapists in Fargo? And they go, no, we don't give out that information. We only give out the massage establishments. Okay, well, then it goes back to who owns that out, who owns the establishment, how can we get the most population for that group? So the first meeting it didn't fall on deaf ears, but we tried to get out there through their Facebook and social media. Subsequently, that's why we held 2 more meetings, because then I talked to the board president and she goes, now I understand what you're trying to do. And they were willing to give me every massage therapist in North Dakota, which I didn't need. I said, I just need Fargo. So the second and third meeting were sent out to every licensed massage therapist because this could directly impact them. So yeah, so then it went out to them, and I don't know what population. I mean, there's almost 200 licensed massage therapists in town. As far as massage establishments, I don't know right now, because illegal or legal, we don't know that either. So, but that's why we wanted to make sure that we took our time. We don't want to rush it. And that's why it was so spaced out too, because massage therapists book their procedures 6 weeks out. So the first meeting, then we said, okay, now we'll go to the next meeting. And that was one of the questions the mayor had when he and I talked about this program as well. I just said, they want to have as much, I want to make sure that the industry has a lot of buy-in, because there again, I'm not a massage therapist, and I want to make sure that these requirements spell out kind of what they want. Does that answer your question? So yeah, we're trying to make sure everybody gets a say in the matter.
Great, thank you.
You bet.
Any other questions for Grant?
I have a question. This is Charlene. When you say establishments, how does this impact, for example, chiropractic offices or clinics that might have a massage therapist on staff?
Yeah, that goes back to that exemptions that I talked about and the administrative code. It's fairly lengthy, and I could send anybody the requirements that we're proposing, but I just literally copied verbatim the exemptions from the state code. And that's like professionals in hospitals, in chiropractic offices that they won't be there again. That wasn't me. That was defined by the state code, the administrative code. And I could send it to you if you want that list, but it does include hospitals and those type of settings.
Okay, thank you.
You bet.
Okay. All right. I know we only have about 10 minutes left, so we'll move on to the next topic. Thanks, Grant.
You bet.
All right. Desi and Dr. Newman, COVID update.
Yeah, I'll just go really quickly too, so we can have any time for questions. Just to give you some ideas of what we're still doing. Obviously, pandemic response is ongoing. COVID testing, rapid tests, and PCRs we have at our storefront location on 25th Street. That has been very, very busy. We continue with vaccination clinics for initial doses on Tuesdays and Fridays, along with booster clinics by appointments on Saturdays for those who have that initial Pfizer series. We are using some contract staff as well for some of these activities, just because we need to kind of supplant our routine staff because of the volume and frequency of the activities. Messaging efforts also continue, along with press briefings when we need them. Still struggling a lot with misinformation in the community, as well as there seems kind of this disregard for those true medical experts, and their guidance has been a little bit frustrating as well. We also see kind of others on social media, different things that are kind of misrepresenting as like self-defined experts. That is also a challenge of ours. Our approach, regardless if we are, popular or not, is to do what is in the best interest of the community and try to combat misinformation with clear guidance and consistent facts. We continue to meet with our physician advisory group as needed to review current recommendations for the schools and in the community, and then look at those various metrics on an ongoing basis to see if we need any changes in recommendations. Continue to see the impacts of Delta in our state. I think last week there was 54 hospital admits across the state and 21 deaths. So far this week, we're already at 27 deaths statewide. Hospitals are really taxed and really struggling with staffing, so that we meet with them every Thursday. And so they are really, concerned going forward. We're not sure, when we're going to peak, what that's going to look like, but we do know that deaths and hospitalizations are a lagging indicator, so that's probably going to continue as long as our community transmission remains in that moderate to high category. Vaccination rates are still lower than we'd like to see them and well below the national average, slightly increasing, but really slowly. And that, of course, is still our number one recommendation for preventing serious illness and death. And it's also going to help us if we experience future surges. So that is really one of our main messages. Other mitigation strategies in the community remain minimal, with little to no mask wearing in public settings, more large gatherings, and those not following or cooperating with isolation, quarantine, or testing. So that's been a little disappointing as well. Still have our one school district in our area that has maintained their universal masking mandate along with their other mitigation strategies. So that has helped them in providing layers of prevention and hopefully buys a little bit of time so we can get those vaccines approved for the 5 to 11-year-olds demographic, hopefully in early November. So Dr. Newman, you want to take it away?
Thanks, Desi, for that speedy update. And thanks, Grant and Ladora, for the information. I know we're running low on time, so I'll try. And I was going to provide just sort of a smorgasbord of updates for you guys, things that I'm following, things I thought might be of interest for the Board of Health if you're asked about them. I'll quick do a pediatric update. So just in general in the United States, since July, COVID-19 cases have risen 240%. And week to week, kind of even as we see our total cases declining nationwide, children continue to make up a larger and larger percentage of those cases. Data show that COVID infections in children reached a new high in September last month, as many schools opened for in-person instruction amid the Delta surge. More than 6 million kids have tested positive for COVID-19 since the beginning of the pandemic, with more than 1.1 million new cases just last month in the month of September. There's also new CDC data kind of getting pediatricians' attention. It was out last week showing a rise in the MISC case reports occurring since August. This is that life-threatening inflammatory condition in kids. It's still considered rare to the individual, but as cases just go up in kids, hospitals are treating more and more cases than we've seen previously in the pandemic. In North Dakota, again, on any given week, childhood cases are accounting for about 27-28% of both new and active cases. Some weeks were upwards around 30%. Our pediatric 7-day average per 100,000 of the population remains quite high. Most recently, we are at 82.5 for the state, 75.7 for Cass County. For perspective, a common metric used is anything 25 per 100,000 is considered out of control spread. So a lot of this data is coming from pediatricians and us just seeking it out on our own. Fargo Cass and others have continually asked the Department of Health to please report childhood COVID infection rates and hospitalization rates on their dashboards and others. So we're anxiously awaiting for that, hopefully. A brief note about vaccination rates in kids. In the US, 12 to 17-year-olds, we're looking at one dose of 57%, fully vaccinated 46%. In North Dakota, they do it by 12 to 18-year-olds. One dose for the state is 36%, fully vaccinated 32%. We're doing a little bit better in Cass County, 12 to 18-year-olds, one dose 51%, fully vaccinated 47%. Still a ways to go. And then I thought I'd briefly touch on the boosters. You guys have probably been hearing a lot about this. FDA advisors met yesterday and today to discuss COVID-19 boosters. And then the ACIP of the CDC will meet next week, October 20th and 21st, to discuss specifically J&J and Moderna boosters. Yesterday, the FDA panel unanimously recommended Moderna boosters for people 65 and older and adults at high risk. So that includes people with underlying conditions or job exposure. And then literally during this meeting, I just got an alert that that same committee unanimously voted to recommend the J&J booster as well. So the advisory committee will also be discussing mixing of the boosters, which I think is going to be really interesting. There was sort of a lot of new data released this week about if you got a J&J booster first, what would it look like if you got a Moderna next second. So stay tuned for that. And then also of interest, Moderna has announced that they are developing a combo booster, which would be both for flu and COVID. It would use their mRNA technology to encode the COVID-19 spike protein plus the flu glycoproteins. So that's very interesting for the future, potentially next year. Novavax is also developing a combo vaccine. It would use recombinant technology for both COVID and flu. Okay, a little bit pediatric vaccine update. So as you've probably all heard, Pfizer has submitted trial data and they've now formally requested for emergency use authorization for 5 to 11-year-olds. This data is not yet peer reviewed or published, but it is available to the public. I've reviewed it in detail myself. It does appear to indicate the vaccine is very safe and highly effective for this age group. The FDA advisors will meet to discuss this on October 26th, and then that CDC's ACIP committee will meet November 2nd and 3rd. So very soon we should have an answer on this. I thought I might briefly summarize the trial data for you guys. Please stop me if you have questions, just in case you want to understand it or you're asked about it. It was very well done. It was a phase 1, 2, and 3 trial. It initially involved 4,500 kids, ages 6 months to 11 years, actually. It was done in 4 countries with more than 90 clinical trial sites. And vaccine safety, tolerability, and immunogenicity of that 2-dose schedule, separated 21 days apart, was evaluated actually in 3 different age groups. They did 5 to 11-year-olds, 6 months to 2-year-olds, and then 2 to 5-year-olds. And so the trials enrolled children with or without prior evidence of SARS-CoV-2 infection, which I think is important to try and mirror what it would look like in real world settings. In the phase 2 of the study, there was about 2,200 trial participants ages 5 to 11, and they ended up receiving a 10 microgram dose, which is a third of the adult dose of 30 micrograms. And actually, all the kids under 5 got an even lower dose of 3 micrograms. And the 5 to 11-year-olds demonstrated a strong immune response, comparing well to, if not slightly better than, the older age group of 12 to 25-year-olds. The vaccine was well tolerated. Side effects were generally comparable to those in the older group, things like fever, sore arm, and there were no incidents of myocarditis in this age group. And then we can expect the vaccine trials of that younger 2 groups, the 2 and 5-year-olds and the 6 months to 2, to come out later this year. So just for scope of this, there's about 28 million children in this country ages 5 to 11 that could become eligible for this vaccine. That would be far more than the 17 million, 12 to 15-year-olds who became eligible in May. Currently in the US, we have about 85% of our population eligible for COVID-19 vaccine. This 5 to 11 age group represents about 9%, so that would bring our total eligibility to 94%. The US government has said they've acquired doses, enough doses to give both shots to all 28 million children. So if this were to be approved in early November, it's estimated that like 20 million doses of vaccine would be rolled out within a number of days. They would use a formula to sort of fairly allocate who got how many initial shots, based on state population of eligible children. And just to note that the pediatric vaccine would have very different dilution and storage requirements than the adult one currently available, and you can't use the adult vials to give to pediatric patients. Okay, I know we're at time limit. I'll briefly touch on the new oral antiviral that's kind of been in the news. This is very exciting. Federal regulators could soon authorize the first antiviral pill for COVID-19. The company Merck has submitted for emergency use authorization just this week for this on October 11th. And it's a drug called Molnupiravir. And in initial phases, phase 2 trials, it involved healthy adults 18 and older. They were treated people that lived in a household with someone who tested positive for and had symptoms for COVID-19. So Merck has said this drug would be used to treat mild to moderate COVID-19 in at-risk adults, and it could also be used to prevent infection in people who've been exposed. So it's thought it would be co-administered with another antiviral we already use called ritonavir. We use this to treat HIV. It is a protease inhibitor that kind of binds to enzymes to prevent the virus from replicating in the cell. And these types of drugs have been really successful in treating other viral infections, as I mentioned, HIV and also hepatitis C. They're generally well tolerated. I mean, if this were to be successful, this therapy could really stop the virus early before it could extensively replicate in people. It could potentially prevent symptomatic disease to those people exposed, and it could really inhibit the onset of infection in others. So Dr. Nagpal and like other ID experts have really stated this could be a game changer for us. This pill could be taken at home, and it could really reduce the burden of COVID-19 patients potentially seeking hospital care or even monoclonal antibody therapy at our transfusion centers. So they did just release their phase 3 clinical trial data, and it showed very positive results for non-hospitalized adult patients with mild to moderate COVID who were at risk to progressing to severe disease and or needing hospitalization. According to the Merck data, molnupiravir reduced the risk of your hospitalization or death by approximately 50%. So pretty significant. But as Desi stated, I just want to say again, while this is promising and could be a game changer, vaccines do remain our best tool for safely preventing COVID-19. I'm happy to take any questions. Thanks.
Thanks, Dr. Newman. I want to check and see, is anybody in the commission chambers for public comment?
No one is present.
Okay, thank you. All right, questions?
I have a couple questions. Going back to the report just before Dr. Newman spoke. You said that Delta is on the rise. Are we testing specifically for the Delta variant?
So they do sampling at the state lab. So when we have the PCR, so none of the rapid or the PCRs don't tell you at that time that it's Delta. They just tell you that it's positive for COVID. Right. And then they send them to the state lab, and the state lab samples, randomly certain percentages. They send certain percentage to the CDC. And last week, again, out of all those samples, the only variant found was Delta.
And what percentage of the cases were Delta cases? Do we know?
I don't know exactly what the percentage that the state did last week. They have increased it from time to time, but I can find that out and I can email that out.
Yeah, I'd be curious to know. Also, you said that we are at moderate to high transmission. What is the measurement for that? For what constitutes moderate, high transmission?
So that's the CDC designation.
Okay.
So they look at our active cases. They look at our positivity rate. They look at our hospitalizations and our deaths. Justin, help me out.
There's like 11 different things. Social Stability Index. I can pull it up on the website here. It's the same standardized risk they do every county in the United States.
Okay. And then you talked about how the mitigation efforts with, for example, the school districts that are applying mitigation, that it is effective. How are we measuring that, the effectiveness of the mitigation?
Well, from the process that they're doing, the more layers of prevention that we can do, the better we are at controlling spread. So it's really hard. I know we've had lots of discussions amongst our community about comparing school districts. It's really hard to do that when you're not necessarily comparing data. Like, for example, for the testing numbers, you don't use the number of kids in the school as your denominator. You have to know how many kids are being tested, how many kids are turning positive, and that number to track is pretty much impossible when you're not doing all of the testing in one site. So they might be going to our storefront, they might be at a health system, might be doing it at school, or they might not be testing at all. So it's really difficult. You have some schools that are doing full contact tracing. You have some schools that aren't doing any contact tracing. Some schools are allowing close contacts to come to school. So there's just all these confounding factors that it's impossible to compare and to say one school is doing better than another. It's just from what for our recommendations, and we have had our physicians advisory group review with us as well. The more layers of things that we can add, the better we're going to do at keeping the spread down.
Right. So the measure of the number of cases isn't an indication that you're successfully with your mitigation. Is that what you're saying?
That's one of the things that we look at. I mean, there's a number of things that we're looking at. You also don't know if that case occurred in the school environment.
Right.
Or if it occurred in the community. When your community transmission is so high, that's, not necessarily equating with what's going on in the school. So it's really difficult to figure out where that came from. I think that's kind of the benefit of contact tracing in the school, so that we can, if we do have exposures in the school, that we can have those kids be out as well. So if there was exposures, that we would stop that early on.
Mm-hmm. So this kind of all goes back to my original question, though, is how do we measure the success of mitigation efforts?
I mean, I think one way is that the cases in schools have been very low. And for example, Fargo Public Schools have not had to close any classrooms. We've not had issues with staff or substitute fill rate. I mean, they've essentially been functioning like normal, including extracurricular activities. To me, that's a mark of success.
Okay. All right, thank you.
I did want to say on the CDC page, they're determining transmission risk is new cases per 100,000 persons in the past 7 days, and also the percentage of positive tests during the last 7 days. So I know that you can correct me if I'm wrong, Dr. Newman, but I think it was something over, is it over 3%? If it's positivity rate, we are missing significant amounts of transmission in the community as well.
Okay. Thanks, Justin, for that follow-up. I know we're well past time. Anybody else have any other questions?
I have a comment, observation from my Boys and Girls Clubs. We have been able to keep children in programming due to North Dakota's double masking exemption. So even though they're considered masked close contacts, they are not needing to be excluded from school or licensed childcare. And that has helped families. I think that's probably where I'm seeing the biggest impact of it. And I'm pleased about the oral. What we're finding is the children that are positive, it's almost 100% their siblings and family members catch it in their households as well. So the double masking exemption, I think North Dakota is one of just a handful of states that allows that. That's been very effective to keep our kids in school and to keep our children in childcare and keep their parents at work and keep our kids learning. So I'm thankful for that exemption.
There's also the vaccination exemption too, that, for those 12 to 18-year-olds that are vaccinated, there too, if they have an exposure, they can just symptom watch and continue to do normal things, as long as they test and are negative test and have no symptoms. So that works well too.
And the test to stay is fairly unique in our nation as well. Is that true?
What's that, Robin?
The test to stay, meaning if you test negatively every couple days or once a week, you can remain in school. If you've been
for the vaccination one, that's just a testing at that 3 to 5 day post exposure. Okay. It's not the every other day to stay in school. That's a little bit different. That's for those kids that wouldn't be vaccinated.
Got it. Thank you.
Okay. All right. Well, I know you all are all very busy, and we appreciate the work that the health department continues to do and keeping our community safe. And so I want to be respectful of your time and know that you have plenty of other things to really get to today. So thank you very much, everyone, for attending today's meeting. And our next meeting is December 17th. So we'll see you all then.
And then look for Lori to send out an email on your favorite days.
Yes. Thanks for the reminder, Desi.
Thanks, everyone.